Good evening, everybody. So my name is Tania Markovic, as Lydia said, and I am an endocrinologist. I've been working in looking after people with obesity for many years since I did my PhD, which was looking at weight loss and how it improves type 2 diabetes. A long time ago, that was in the 90s, so many years of, and now I am the director of the Metabolism and Obesity Service at Royal Prince Alfred. So so 1990 was around when I started my PhD, and we already knew obesity was a problem, but things have changed for the worse, as you can see in this oldish cartoon now. So my brief was, and I just copied this word for word from a text I got, email I got from Lydia, was to talk about the medical management of obesity, the realistic approach, where to next when diet and exercise failed. So I'm going to briefly mention diet and exercise, really focusing most of this talk on injectable treatments for metabolic health and weight loss, risks, appropriateness in people without diabetes, the cost, and a little bit about the Metabolism and Obesity Service, our referral pathway, and what we do. So, I'll just move this thing out of the way. So I'm sure most of you have seen the slide, either this slide or a slide similar. Why do we make such a fuss about obesity? Because it is linked to many problems. In fact, just about every body system can be adversely affected by obesity. Oops, next. So, yes, obesity causes many diseases, but can we achieve anything with weight loss? And the answer is yes. And what is interesting is that you don't need a huge amount of weight loss for some conditions. Diabetes prevention, as little as just a few percent weight loss, as little as 3% weight loss can result in prevention of diabetes. For other conditions, greater degrees of weight loss are necessary. Oh, I'm having problems here. I won't touch that. For example, for fatty liver disease, you need at least 10% body weight loss to see improvements. One of the biggest challenges with weight loss, most of us, 70% of us are overweight or obese, so most of us have been on a diet, and we know that we can lose weight. And in fact, with some approaches, and on this slide, the approach that's done the best is the very low energy diet, where this amalgam of studies where there was 18 kilos of weight loss, we can achieve this, but the maintenance of the weight loss is the problem. So we tend to gradually go back to our old habits. Appetite hormones may change adversely, and we regain the weight. And it's not only with, here we see diet, exercise, sibutramine, an old-fashioned, a drug that was actually quite effective for weight loss that's no longer available, orlistat, which is still available in very low energy diets. But even for the treatment that's considered the best or most durable, bariatric surgery, you can see that in the 10 years following bariatric surgery with the various different procedures, this is from the Swedish obesity study, there was increasing weight gain. Looks like it after 10 years, not so much, but the numbers are getting quite small for some of these procedures. And of course, as we age, we tend to lose weight, muscle mass. So I think we'd all agree that obesity is a chronic, whether it's a disease or not, that's up for debate. Most of my colleagues like to call it a disease. I'm not so sure, but it's certainly a chronic condition, and it certainly requires treatment. So what are the options? And I'm sure you're all familiar. Lifestyle is important, and it really needs to be part of just about every additional treatment. Very low energy diets have a role, pharmacotherapy, and bariatric surgery and endoluminal procedures. Certainly bariatric surgery and endoluminal surgery are not going to be effective without lifestyle modification. Pharmacotherapy also needs it, but the newer agents make diet much easier. So diet, very quickly, I need a clock so I'm not running out over time. Peter, tell me when I'm halfway through, please.
Sure.
So I know to skip some slides if I have to. So diet prescription, look, there's every year there's a new fad, but over the 20 plus years I've been in this space, there's no doubt that cutting your calories or kilojoules works and needs to be done. It can be done more easily by cutting out energy-dense food. We know that there's reduced cardiovascular mortality if we eat lots of fruit, vegetables, whole grains, and fish, and maybe a bit of olive oil as well, and that's the Mediterranean diet. Eating meals regularly, I think, is important, whether it's 2 or 3 meals, just depends on the person. There is some evidence that having mid-meal snacks is not helpful, because the more opportunities you have to eat, the more you eat. And of course, if you are eating healthily, you can have treats from time to time, but it's not every day. So I really like this slide, and it just, every single plate has the same amount of kilojoules, 840 kilojoules, and it gives you an idea of why eating fruit and vegetables might make you fuller, and might make it easier to not gain weight than by eating, for instance, that 56-gram biscuit thing. That's just half a biscuit. And I've just put down the bottom how many kilojoules we should be eating. And for weight loss, it's recommended, around 1,500 calories, 6,300 kilojoules. So you can get that fairly quickly if you have a packet of biscuits, like some people might have. So physical activity, also very important for many reasons. It is so important for our metabolic health, our psychological well-being, even reducing the risk of dementia, which is something I think we would all want to avoid, us and our patients. Often for our patients, particularly bigger patients, ones with joint disease, it will be uncomfortable. You need to assess what they're actually capable of doing. No point telling them to do 10,000 steps a day when their baseline is 500, which for some of my patients it is. And even if there is no weight loss, there will be metabolic improvements. It's worth spending a bit of time looking at what people are doing in their day-to-day schedule, and look at increasing just their daily activity, just incidental activity, because not everybody likes to go out and exercise. I should have also highlighted that not only is aerobic exercise, walking, swimming, kayaking, whatever you enjoy, important, but we're recognizing anaerobic muscle strengthening resistance exercise as being important, particularly beneficial for joint disease, probably the best treatment for joint disease, and very good for our bones, for maintaining bone strength, anti-osteoporosis. You should probably do a combination of both. Now, very low energy diets. This is something that we've been using at Metabolism and Obesity Service since before I did my PhD. I went there and remembered to learn a bit about it, because that was something I used really just as a tool, as an intervention for my PhD, to try and get quick weight loss. And what it is, it's really, I think you could describe as a healthy type of keto diet. It's the most intensive dietary intervention. It's only 800 calories a day. That's the definition, less than 800 calories a day. It involves the use of meal replacements to replace meals. And the idea is that these meal replacements are nutritionally complete with all the necessary vitamins and minerals. They can be used for anything from 2 weeks, which is what we typically do before bariatric surgery, to reduce liver fat. And we typically run our programs for 3 months, but patients who do well with it often want to remain on it for longer. And it results in rapid weight loss. You do need support. It's not easy. I mean, there are aspects of it that are easy, the limiting the choice, but it's if you're somebody who enjoys food, it's not necessarily a lot of fun, but it is very satisfying for patients to see the weight loss that they achieved. And our colleague over in England, Michael Lean, did a study we should have thought to do, but he was clever. He did it in primary care. And this is called the DIRECT trial, where he put people, various primary cares were enrolled. Some patients were treated with a very low energy diet, others with just standard care, and you can see the large weight loss that was achieved in those who were on the very low energy diet. These are people with type 2 diabetes, stopped all their diabetic medication, and at the end of 12 months, they had around 13% body weight loss on average. This slide shows you the chance of achieving remission, and the more weight loss that was achieved, the greater the chance of remission. In the light, this orangey color is after 1 year, and then in the darker, the pinky color after 2 years. So that even after 2 years, 70% of those who had at least 15 kilos, which in this cohort was around 15% body weight, their average weight was 100 kilos. There was remission of type 2 diabetes. This is with people with diabetes up to 6 years duration. We repeated this study in New South Wales with support from a number of PHNs, and we showed very similar results, again, in people with diabetes, those who achieved at least 15% weight loss after a year. The black is the intention to treat, the grey is the completers, but very high amounts of remission of diabetes. So on to what we really want to talk about, which is the magic, these magic potions. So drink this potion. Anyway, you can read that later. That's meant to be funny. Medical students never laugh at my jokes, so I've pulled them out of my medical talks. So when should pharmacotherapy be considered? So it's recommended in people with a body mass index above 30, or those with a body mass index above 27 with comorbidities, and certainly those with central obesity, and people of non-Caucasian background, particularly Asian, our Indigenous people who are more prone to central obesity would probably qualify for these medications at lower body mass index. Body mass index has many limitations. So people who are regaining weight after they've reduced their weight, people have had injuries that could promote weight gain, to promote weight maintenance of weight loss after an intervention, such as a very low energy diet. They can be used in weight regain, which can occur and does occur following bariatric surgery, possibly following a recent diagnosis of an obesity-related comorbidity, and in women seeking fertility. But of course, they should be on contraception. They shouldn't be trying to conceive while they're on one of these medications. So these are the medications that are currently approved in Australia. Orlistat, which reduces the absorption of fat from the gut. It was actually developed as a cholesterol-lowering agent, and it does have additional independent effects on LDL cholesterol. Phentermine, which can be used short-term, 3 months at a time. A sympathomimetic amine that suppresses appetite and increases blood pressure and pulse. Then we've got the GLP-1 analogues. The first one to be approved was liraglutide, a daily injection, and more recently semaglutide, a once-weekly GLP-1 analogue. And then finally, naltrexone bupropion, which is 2 agents that work together to increase a hormone called alpha melanocyte stimulating hormone that reduces appetite. And these are meant to be particularly good for reducing hunger and cravings. Now, where's that one doing? Oops. So just very quickly, really what I want to emphasize in the next few slides is the amount of weight loss achieved. So, beg your pardon. So with Orlistat, you can see in this particular study that went for 4 years, one of the longest pharmacotherapeutic trials in obesity, there was quite good weight loss of around 10 kilos. which you see the regain, so that by 4 years there was about 6 kilos. And associated with this were improvements in, and you always have to look at this, of course, improvements in all the comorbidities. It's quite a good drug, except that it does have bad side effects. If you have a high-fat diet, a lot of diarrhea, or even problems, even soiling your underwear, you might have to run to the toilet. So not something that people particularly like, and you need to take it 3 times a day. The next drug, naltrexone and bupropion, which is the trade name is Contrave, not brilliant for weight loss, so just around 5 to 6% body weight loss, and also has substantial side effects, nausea. It can increase the blood pressure and heart rate. It needs to be taken twice a day. There are certain contraindications. So not a drug I use all that much, I have to say. Now, phentermine topiramate, this is something that we have been using until the GLP-1 analogues came along, and that we still use in certain patients. These are the phentermine, duramine, in combination with topiramate. They have different mechanisms of action and work quite well together so that you can manage on a much lower dose of phentermine. And but importantly, they're not approved, TGA approved for obesity in Australia, but they have been approved in the United States. And the reason that we use them is that they're quite effective. So the dose in the actual trials of phentermine, the usual phentermine dose is anywhere between 15 and 40 milligrams. And most patients using it as a single agent will use 30 to 40 milligrams. But in the trials, a dose as low as 7.5 milligrams was used. We routinely at Metabolism and Obesity use 15 milligrams with initially 25 milligrams of topiramate. And you can see there around 12% body weight loss with the higher dose at 1 year, and at 2 years around 10% body weight loss in the combination high dose, but significant side effects again. So with topiramate, paresthesia, dryness of the mouth, also it can affect cognition. Phentermine, headache, insomnia, constipation, high blood pressure, pulse, increase in pulse, shouldn't be used in people with ischemic heart disease, significant depression. So that really does exclude a lot of the patients that we see, and important fetal toxicity. So really, as background, I think that show those that they are the drugs that we have had available for most of my working life. But now we've got, I call it, it really is a revolution in obesity management. And I know there's been a lot of hype about it, but I don't think, I think it's fair that it's made a big difference, because we finally have treatments that are safe and effective. We've had treatments that have been effective, but often not all that safe, which is why in my career, a number of obesity medications have actually been pulled from the market for various reasons. So, so the drugs, sorry, I don't know if this blocks my screen. Ooh. Very good at technology. I'll just move that out of the way. So this slide shows you the two, in the agents that we have available in Australia now, they are predominantly glucagon-like peptide 1 analogues, but tirzepatide, which is marketed as Mounjaro, is a dual glucagon-like 1 and glucose-dependent insulinotropic polypeptide analogue. These are both gut hormones produced in the gut, in the small intestine after we eat, and they have a large number of effects that you can see all the organ systems that have been shown to be involved in animal and human studies of relevance. And on the left is GLP-1, on the right is GIP, is that they act centrally to reduce caloric intake. They don't really have any effects on energy expenditure. They both increase the heart rate through effects on the sinoatrial node. They, in a glucose-dependent manner, increase insulin secretion, hence their use and efficacy in type 2 diabetes. And importantly, if your glucose levels are normal, there is no insulin secretion, so there isn't the risk of hypoglycemia. Oh, beg your pardon. Again. The GLP-1 reduces gastric emptying, whereas GIP doesn't have much of an effect on motility, gut motility. This, I think, explains a small advantage of tirzepatide, which is that the gut side effects aren't as bad as with semaglutide or Ozempic. There are also effects on the kidneys, beneficial effects on bone modeling that certainly don't reduce bone density. And I should have mentioned another difference between the two hormones, between these two hormones, is that GLP-1 reduces glucagon secretion, whereas GIP increases it. So let's have a look at what they do for weight. And this drug is liraglutide, marketed as Saxenda, 3 milligram daily dose. And you can see that there is weight loss. It's similar to a lot of the older agents I've shown you. So, around 9% in those who are actually on the treatment. Sorry. Missed one slide. This. Yeah. So that's liraglutide, which has also been shown, which also at a lower dose, at a dose of 1.2 to 1.8 milligrams, is used for is approved for type 2 diabetes, and it is associated with improvements in renal and cardiovascular outcomes in people with type 2 diabetes. Now, why has Ozempic been such a sensation? Actually, I should explain the terminology. Semaglutide. So Ozempic and Wegovy are two products marketed by Novo Nordisk, the drug maker. Ozempic is the 1 milligram once weekly dose, or 0.25, 0.5 and 1 milligram dose of semaglutide, which is effective at reducing glucose levels. Higher doses have a small extra effect, but not much. So the company decided that the 1 milligram dose would be the dose for diabetes. Pushing the dose up to 2.4 milligrams results in the maximum efficacy for weight loss. And this product is called Wegovy. So the 2.4 milligram dose of Wegovy has been approved in Australia for weight loss. Was approved a long time ago, actually, but Wegovy's only just hit the pharmacies in the last week or so. And you can see the weight loss is really very impressive. So much greater than anything, well, actually, close to what I showed you with the combined semaglutide to pyramate, a little bit better, maybe. Of, around 15% body weight loss compared to, and then placebo, you're seeing a couple of percent body weight loss. And then when we look at categorical weight loss, so this is the proportion of patients who achieved either 5, 10, 15 or 20% weight loss. If we look on the right, this is the people who are actually on treatment, whereas this is the people who were randomized. So in the trials, they can look at who was randomized to what, and then they can determine what people actually took. So this is, I guess, the more real data. And this is really over 50% had more than 15% body weight loss, just under 35% had more than 20% body weight loss. So it really is quite fantastic. And importantly, before I get to what's important, more important even still, tirzepatide, what does it do for weight loss? So this is the dual GLP-1 GIP co-agonist. And this is the data for type 2 diabetes. People with type 2 diabetes always lose less weight than people without. And you can see quite impressive weight loss of around, depending on the dose, up to 11% with the 15 milligram once a week dose. Then we go on to tirzepatide for people with people with obesity without diabetes. Now, I should have said tirzepatide has been approved, and this is Mounjaro, has been approved in Australia for management of type 2 diabetes, but has not yet been approved in Australia for weight loss. It has been approved in the US, the UK, and Europe for weight loss. And here we see amazing weight loss of 21% on average with the high dose. I'll just point out to you that the 5 milligram dose of tirzepatide, so the high dose is 15 milligrams, the 5 milligram weight loss dose is very similar to the 2.4 milligram tirzepatide dose at around 15% body weight loss. That's the important finding there. And maybe just to highlight that 39% of people lost more than 25% of their body weight loss in this trial. 63% on the 15 milligram dose, 63% lost over 20% weight loss. So it really is similar to what we see with bariatric surgery.
And we're halfway through.
Thank you. Good. So not only, of course, whenever we've got a weight loss drug, we always have to look at, yes, it's good to lose weight, but is it resulting in a health benefit? Because not all forms of not all weight loss medications have resulted in health benefits. But boy, do these incretins result in health benefits. So this is some data from semaglutide, looking at renal and cardiovascular benefits in people with type 2 diabetes. Now, of course, people with type 2 diabetes are at higher risk of these conditions, so you're more likely to see, if there's going to be a benefit, you're more likely to see it. But you can see for cardiovascular outcomes a clear, quite early separation, which has led people to suggest that maybe it's not just the weight loss, but something about these agents that is resulting in this benefit. So the hazard ratio of 0.74 means a 26% reduction in a composite of cardiovascular death, myocardial infarction, and stroke. Similarly, with a kidney event, kidney disease, a significant 24% reduction. The SELECT trial, this is a trial again, with semaglutide in people, in this case, with obesity who had a history of cardiovascular disease. And again, very impressive data where we see a 20% reduction in their primary composite outcome of various cardiovascular conditions, which again, you see this very early separation here soon after starting in the trial. Tirzepatide, there are ongoing trials looking at cardiovascular outcomes. They haven't been published yet, but just recently a trial looking at effects of tirzepatide on sleep apnea showed very impressive results. And I've just put there our colleague Ron Gruenstein was a second author in this New England paper. So a massive reduction in the apnea-hypopnea index. There were two trials. I don't think you need one. In trial 1, there were people who were not treated with CPAP at baseline. Trial 2, they were. 50% at the end of the trial, which went for a year, 50% no longer met the threshold for requiring CPAP, which is quite fantastic. There are a number of studies that have shown, they're fairly short studies, less than a year, that with semaglutide and a few and other GLP-1 agonists that have shown reductions in steatosis. This is the first trial that's hinted at a reduction not only in metabolic associated MASH, steatohepatitis, but also fibrosis with a drug called survodutide, which is a dual GLP-1 glucagon agonist. And this showed the primary endpoint, which was an improvement in MASH with no worsening of fibrosis, which was achieved with all doses of survodutide. And then when they looked at the secondary endpoints, there was a suggestion that of an improvement in fibrosis and reduction in liver fat content with survodutide compared to placebo. Now, of course, I've shown you all the good news. So that really the point about this is we're getting phenomenal weight loss and we're getting improvements in cardiometabolic disease. There are adverse effects, but compared to the older agents, they're fairly, they're much less and much less concerning. The most common are the gut side effects, nausea, which according to Professor Nauk, who's considered a world expert on these agents, he a nice review paper of his I read, he suggests that the nausea is centrally related, but other colleagues, it slows gastrointestinal emptying, and probably that's part of the story. I should have said that the reason that we increase the dose so slowly is because there is some tachyphylaxis to the nausea. And if we start at the high dose, no one would tolerate it. So you need to start at the low dose, gradually increase it. And it's quite individual how bad the side effects will be. Some people have minimal, some people are extremely sensitive. The next most common side effect is diarrhea, followed by vomiting, and in some people constipation, and some can get a combination of diarrhea and constipation. And dyspepsia is certainly described a lot by patients, not mentioned so much in the trials, but something a lot of patients complain to me about. Biliary disease, particularly gallstones, and I've just quoted there, this is from the large semaglutide weight loss trial, where it was 2.6% in people on treatment and 1.2% in those on placebo. So we know that gallstones are increased in people with obesity, and certainly increase when you lose weight, but probably also partly to do with the mechanism of action. Pancreatitis, there's been some debate about this, and I was convinced by a few articles that it wasn't a problem, but now that I've seen quite a few patients who've had it with semaglutide, and then it's improved when they've stopped it. It's rare. It's much more common in people with obesity and diabetes, but I am pretty convinced that these agents do increase the risk. But fortunately, it's very rare. Something else that I'm just going to alert you to is there were reports of, I think there was a report of possibly, a death when somebody was anaesthetized who had taken a GLP-1. There was aspiration in the US. So there have been other case reports. So a group of experts in Australia have come together to develop guidelines on what to do before surgery or endoscopy. Importantly, they concluded that there was insufficient data to support omitting GLP-1 or GIP agonists before endoscopy or surgery. And this is really very important for people with type 2 diabetes, because I've had some patients who've been told to stop it, a month before surgery, and their glycemic control is likely to deteriorate, which is not a good thing. So there's no evidence to stop them, but there are guidelines such as if you're having an endoscopy, to have clear fluids for 24 hours before. If you're having other surgery, you need to be treated as if you're not fasted. Anyway, you can read those. They're quite practical. So let's get on to the actual nitty-gritty, the cost, and these agents are not cheap. And usually I show a slide showing that that obesity is very much a socioeconomic disease. It is much more prevalent in even in Australia, in suburbs of lower SES. But unfortunately, the drugs, particularly these very efficacious ones, are quite expensive, as you can see down here. And what's going to create a lot of problems is that Ozempic, as you would know, costs for the 1 milligram dose is about $170, whereas Wegovy, exactly the same drug, 1 milligram dose is $260. So that is clearly going to create problems. Apparently, Novo had to do this, had to have the low price in order to get Ozempic on the PBS. But first of all, how do I prescribe incretins? And as opposed to what happened in the trial. So in all the weight loss trials, the dose was pushed to the maximum. So in the semaglutide dose, the dose started at 0.25 once a week, then 0.5 milligrams for 4 weeks. Then the dose was increased to 0.5 milligrams for 4 weeks, then 1 milligram, then 1.7, then 2.4. If people felt very unwell, that you could go back and reduce it and then try again. Various guidelines as to that, and very similar for tirzepatide, starting dose of 2.4, increased at 2.5 milligrams once a week, increased by 2.5 milligrams every 4 weeks up to the 15 milligram dose. It is not what I do in practice, nor what people in the United States, I heard a nice webinar from there, do in practice, for many reasons. First of all, why increase the dose if you're getting good appetite control on a lower dose? It's just going to cost more. There's no point. So I use the minimum dose that will control appetite. I will tell my patients not to increase the dose. There's no point increasing the dose if you're getting gastrointestinal side effects on a certain dose, because they're only going to worsen. In fact, you may even want to reduce the dose. Somebody might be on a certain dose for a long time and it can be working, and then for whatever reason, they might need to increase the dose in time. That's what I've seen in some of my patients who've been on these sorts of treatments for a while. Before we go to that, so tricks of the trade. This is a very naughty slide, you've probably, your patients are counting clicks, and what does all that mean? With these pens, you can actually titrate the dose. The way the pens work is, as you know from the Ozempic pens, is if you're on the starter pen, it's got the 0.25 and the 0.5 marked on it, and then the maintenance dose pen, the 1 milligram, just goes from 0 to 1. But if you count the clicks, you can give 0.5 milligram or whatever dose you want. And the same thing applies to Wegovy. And one of the pharmacists here, one of the chemists has worked this out for me, that in the 2.4 milligram pen, there's 71 clicks. So if somebody, and you get the most value for money with the high dose pen. So as the pen goes up in dosage, it's milligram per dollar cost of the medication reduces for both Wegovy and Mounjaro. So if our patient wants to save money, they're better off getting the highest dose pen and doing this click counting, which is totally not what is recommended by the TGA or the makers of the manufacturers of these drugs. It's just what we do to make it affordable for our patients. Same thing with Mounjaro. The pen that will be available, it's currently in vials, but will be available mid-September, I've been told, is just the same as the quick pen used for insulin, which it's very handy. It's got 60 units or 60 clicks, and the 1 month pen with 15 milligram dose will have 60 milligrams. So 1 milligram will be 1 click. And without laboring it, the 2.4 milligram semaglutide and the 5 milligram tirzepatide have similar weight loss, but you can see the cost is different if you do it this very non-kosher way, I think one could say. So next question we often get asked is, how long should pharmacotherapy be used for weight loss? Well, really, like anything else, probably long term. This is a study where patients were on treatment for a year and then they stopped treatment, and you can see that the weight did gradually increase in those who were on placebo. Interesting, the placebo effect, their weight dropped, and then when they stopped the placebo, their weight also increased. It increased to a lesser degree with those who achieved more weight loss, which is interesting. So even so, you know, maybe people who've had very good weight loss with these drugs can manage on a lower dose, or can go on and off it. We've certainly done the human experiments while we've had all the availability problems, and I know that on the whole, all my patients regain weight when they stop these drugs. Just as the weight reverses, the weight loss, you regain weight. Also, there is, in this trial, this is showing you the people who reverted from pre-diabetes to normal glucose levels, the proportion, over 68 weeks. And then when the drug was stopped, the pre-diabetes came back. So the metabolic effects improvements also do not persist when you stop the drugs. And same thing with the other cardiometabolic parameters like blood pressure, C-reactive protein, and HbA1c. So in the last little section, Metabolism Obesity Service, who are we? It looks like there's hundreds of us there, but in fact there was until a few weeks ago just 0.7 medical full-time equivalents, but we've just got the fabulous Marissa Portelli working with us through a pitch thing, because there's no money, but she won the pitch at RPA so she's been funded, which is wonderful. And we've got 3.6 full-time equivalent nursing and allied health, which includes our clinical psychologist for 1 day a week, nurse, physio, and these lovely dietitians. And we've got, we often have a visiting fellow, and we've got Dr. Ahmed Bahamdin, who's been terrific and actually a great help now that we've trained him up. So at our service, we have, there is a pediatric service. It's very small, that's dietitian only. There is a healthy lifestyle and diabetes prevention clinic for people with lesser degrees of obesity who are not as unwell, run by Professor Luigi Fontana at the Charles Perkins Centre. Our main service is the complex obesity service, which is a service for adults with severe obesity, BMI above 50 or a BMI above 30 with severe comorbidities. And then we also have, and I'm not going to talk about it tonight, but a Prader-Willi syndrome service, and we do look after people with intellectual disability and severe mental illness and obesity and metabolic disease. So, so what happens? So you send us a referral, then we send, and it's very important that the patient completes this. You can help them with it, an initial assessment form, because on this form we get important information that guides us how to triage the patient. Most of the patients will end up doing one of our group programs unless there's a language issue or intellectual disability or severe mental illness or Prader-Willi syndrome, where they'll see somebody one-on-one from the outset. But most will join one of our group programs, and that will be either our Bodylines predominantly lifestyle program, or our rapid meal replacement program, which is with the very low energy diet. They will, after they complete this program that lasts 3 months, there's a medical report that you'll receive where I review all the referrals and pathology. We ask patients to do pathology beforehand, screening mainly for metabolic disease, which I'll comment on and give you some advice. And only after this will the patients actually see someone. And so this method means that we actually have very little, I shouldn't publicize this, but our waiting list is minimal. Because this is a barrier for some patients who aren't quite ready. You know, they're hoping that they'll just come and see us and get an operation, but it's not that simple. So then they will have the individual appointments, and then one of the options is to proceed to bariatric surgery. Now, I also just wanted to give some publicity to the Australian guidelines, very practical guideline and a living document that we update all the time. The Australian Obesity Management Algorithm, which again, a bunch of learned societies got together to create this. And the ADS has done a really good job. I couldn't put it up, but they've got I've just looked at it today. If you go to this website, there's an interactive guideline where you click and answer questions, and then it directs you very clearly to what treatment options you should consider. Dividing people based on their BMI and comorbidities, and as to how intensive the treatment will be. And I think that's my last slide. Yes.
Thanks very much for a great talk, Tania. Look, it has generated a few questions. I must say, one of them is a question that I wanted to ask myself about patients regaining weight after stopping the drugs. The studies that you showed, I think, went out to 120 weeks. What can we expect after that?
Look, my
Because we have a question that asks, what can we do to stop patients regaining weight after stopping the drugs? Do you have any tips to give, such as water before meals, adding fibre powders to meals, cleaning teeth before eating? Any tips welcome.
yeah, well, look, I think I tips. I wonder, and the studies haven't been done, but I wonder if patients are on these drugs for some years, whether their behavior changes so that they might manage on a lower dose.
Mm-hmm.
I certainly know that in the short term, if you're on it for a year or less and you stop the drug, the weight comes back. All those tips might be helpful for some people, and some people do manage to reduce weight without weight loss drugs with those sorts of tips, all those things that you mentioned, and all the diet and exercise, they manage to implement that. But a lot of us don't, and there's why we eat is so complicated. The patients that I see, a lot of them have extremely stressful lives. They often don't even realize they're eating when they're eating. There's comfort. They don't know how to cook. We've got a lifestyle, or how to, not, I should say, they don't know how to cook healthily in a way, in a way that's not expensive, using food. It sounds very basic, but there are a lot of skills that are lacking. And we actually now have this, have a chef at the Charles Perkins Centre. It's not us, it's Luigi, Professor Fontana. There was some money and he managed to sort of doing it as a trial, but there's a chef, Marzio, who worked at a famous restaurant, I can't remember which one, who shows people how to cook healthily and cheaply. And one of my patients went to the course and said it was fantastic. The only problem was, because of jolly health and safety requirements, they're not allowed to try the food, which I think is incredibly cruel. But
I have another question that starts off by saying that diabetic remission is not a cure, even if diabetes treatments can be reduced. So these patients still need to be followed up long-term very carefully, do they not?
Yes, I totally agree. So they're in remission. So it's because they've lost the weight. They've always got the predisposition. And if they put on weight, their diabetes will almost certainly come back. So yes, that's absolutely correct.
There's another question here about anaesthetic risk, and I think you covered that during your talk. But as part of the question is also a reference to NION, which is non-arteritic ischemic optic neuropathy with the use of GLP-1 receptor agonists. Any comment there?
Look, there was a report and I did read it. If it happens, it's extremely rare. I remember, look, I can't remember the details of the article, but I remember after I looked at it, I wasn't too worried about that. Sorry, that's not the perfect answer, but look, compared to all the other problems that people have with their weight, if it happens, if it's linked, it's extremely rare.
And the relative difference in...
But I should say that there is a risk of retinopathy worsening, and this is probably because of a rapid improvement in glycemic control. That is something that we see not only with GLP-1.
Yeah, not only with GLP-1. Yep. Okay. Incidence of serious side effects like pancreatitis, Mounjaro versus semaglutide, is one of those more or less favourable?
I don't think we have the data to say that. I treat them both with caution and certainly watch out. If patients complain of, it's not something that's top of mind because it's rare. But if patients complain of abdominal pain or anything that alerts you, you do need to have it at the back of your mind.
And what sort of percentage of patients stop Ozempic or Mounjaro because of side effects?
Look, that's a good question, and it is in the trials, and I should know the exact number, and but it's in the order of 5-10%, I think.
Okay,
I might look it up. You know what I'll do? I'll look it up while David's talking.
Okay.
So I can
because the questioner says, is it as high as 40%?
No, I don't think so. But I'll tell you one important trick, what I do, And I've got patients with diabetes, centrally obese, who desperately need this drug, and I've pushed them to do it. I've started with mini doses, like tiny, tiny doses. So, you know, the usual starting dose is 0.25. I've used 0.1 or 0.05 and done it very slowly, and it's been successful. So if the patient is prepared to, you know, try it, and you're prepared to patiently start at a very low dose, I think most patients will tolerate it.
Another question is, do the people on very low calorie diets get ketones in their urine?
They do if they're following the diet properly, because that's the whole, I didn't spell it out, but the whole idea is that you're having very low carbohydrate intake. So with our very low energy diet, we always recommend having green vegetables, low joule soups, low joule jellies. And the whole idea of having the vegetables is so that you a bit of variety, and also patients for the first time, a lot of them start eating vegetables and cooking vegetables, and our dietitian's very enthusiastic and provides recipes and how to make it interesting. So the idea is that it's very low in carbohydrates, so you are getting a mild degree of ketosis, much less than you would get if you had type 1 diabetes and you had ketoacidosis. You know, it's sort of tiny. But that degree of ketosis does appear to help with appetite control, and that's something Joe Prieto, a colleague in Melbourne you might have seen on TV, has nicely shown.
Okay. Another one asks you to look into your crystal ball. When might Mounjaro obtain TGA approval for obesity?
Oh, look, I'm not on their advisory board, and I've got a colleague who is, and I should have asked her, but I really think it'll be soon. I should say that I'm prescribing it. I have been prescribing it since day one, since its availability here, because I feel confident that it's a safe drug and a very good drug. But I always tell the patients that they're taking it off label. Look, it is a risk doing that. I'm prepared to take that risk. I don't expect others to be prepared to do that. But I think it will be approved soon.
Is there any role for antiemetics in treating the nausea induced by GLP-1 receptor agonists?
Look, I've not used it for these drugs that I've talked about, but I'm involved in clinical trials at Charles Perkins Centre, where one of the drugs we're using seems to result in a lot of nausea. It also looks like a really good drug. And we've used ondansetron with it, and that's been helpful. I mean, it's pretty potent antiemetic. But yes, they can. There's no reason why not. They don't interact, so it's not dangerous.
Can you tell us about the use of these drugs in pregnancy or pregnancy planning?
Pregnancy planning, if you're using contraception, is fine. We don't really have the data to say whether they're safe in pregnancy. I have seen something published where they looked at pregnancies in people who accidentally were on the drugs, and it didn't look adverse, but the recommendation is definitely not to be taking these drugs when you're actively trying to have conception.
You've told us that before proceeding to bariatric surgery, patients will be on very low calorie diets. Should they be given a trial of GLP-1 receptor agonists before bariatric surgery?
Look, often they are. The big problem is that should they be given? The problem is the cost. So at the end of the day, for example, for our public patients, because some of them can get bariatric surgery in our clinic, they're obviously getting it through the public, they're not paying for it. The bariatric surgery is cheaper for them than, much cheaper, because they have to pay for the obesity medication. Now, if somebody is self-funding their bariatric surgery, I would try a GLP-1 first. Now, if you asked another obesity expert, they might have a very different answer, but I would be using one of these, and particularly for younger people, because there's more and more of these drugs coming out. It's going to be a very different landscape in a few years' time. You know, the amount of trials we're doing on various combinations of these gut hormones is amazing. And undoubtedly, there's going to be generic medications also. I mean, it'll be a little while, but I mean, there already are, but there'll be properly studied generic medications in, I don't know, 10 years or however long the patent, apparently in China in a matter of years.
Mm-hmm. Look, a very quick one. Does your service at RPA accept e-referrals?
We're trying to set, you can certainly send a referral by email. That's e.
Mm-hmm.
But look, we were trying to set up an e-referral system for the SLHD, but I believe that that's not happening anymore. So unfortunately not.
Okay.
Not a strict e-referral, but certainly emails are fine.
Very low calorie diets, do they need to be supervised by a dietitian or by a doctor?
I think a patient needs the support of somebody who understands the diet. So it can be either a dietitian, a doctor, or in fact, in some of the trials, there've been sort of nurse, allied health people. And in our clinic, we've got physios and nurses supporting. So as long as you understand how they work and you're able to support the patient, I think there are plenty of patients who will use them on their own. And often I've met patients who've used these very low energy products on their own and they haven't lost weight. And that's because they probably haven't done it properly, or it's quite hard to do it without somebody supervising. I don't think it's dangerous, but I think you'll get better results if somebody who understands the treatment has explained it, and if there's somebody there to answer questions and help and give you support.
Look, I apologise to the attendees whose questions we're not going to be able to get to because we have run out of time. But an interesting little one here for the end, Tania. One of our patients had a case of unremitting hiccups with semaglutide. Is that something that you're aware of?
I'm just trying to think. I've had a patient recently who's had hiccups, and I'm trying to remember whether it was with semaglutide or not. I've only can think of one patient who's had that, and I can't remember if it was a he, if he was on semaglutide. No, not something I'm really aware of. Hasn't been reported.
Okay. All right. Well, look, we'll leave it at that. Thank you very much for a great presentation, Tania, and for fielding those questions for us. Thanks very much.
Thanks. And Peter, I'm happy to stay on if somebody has a burning question at the end when David and Madeline have finished.
Okay, that's great. Well, thank you very, very much for that.
Thanks.
Okay, let's go on to the second part of our presentation for this evening, which is going to be concentrating on an update in lipid management, especially with situations such as familial hypercholesterolemia. And we have two speakers for that topic this evening. One is Associate Professor David Sullivan, who I'm sure doesn't need any introduction to an audience like this, but we'll give him one anyway. David's a physician and chemical pathologist in the Department of Clinical Biochemistry at Royal Prince Alfred Hospital. He has a long-term interest in lipid metabolism, with particular emphasis on the environmental component, especially dietary, of gene-environment interactions contributing to cardiovascular disease. His other main interest is the improvement of detection and management of severe inherited dyslipidemia, such as that seen in familial hypercholesterolemia. I'd say a lot of us would have patients with FH in our practice, just a question of us going looking for them to find them. Now, also speaking will be Madeline Calder. Madeline's a genetic counsellor at the RPA. She works alongside David in the Vascular Health Clinic, and she specialises in metabolic disorders, including familial hypercholesterolemia and porphyria. Madeline is also involved in a number of research projects, with her current focus being on the implementation of familial hypercholesterolemia cascade screening into the primary care setting. So I'm not quite sure who's going to kick off for us.
That'll be me. I'm going to start
Madeline,
first
there you are. You're
before
starting
handing
off.
over to the
Yeah.
expert.
Madeline and David are going to do a tag team here to get through the topic. So thanks very much, Madeline. It's over to you.
Thank you very much. Okay. All right. Thanks for that introduction, Peter. As he said, my name's Madeline. I'm actually a genetic counsellor here at the clinic. And just a brief overview of what we're going to be talking about today. So, is that progressing through the slides there? No, it's not. Oh, there we go. So just give everyone a brief introduction on hypercholesterolemia and familial hypercholesterolemia in particular. I'll then go on to have a chat about cascade screening for FH before sort of finishing with what our service can kind of offer, and then handing over to Dr. Sullivan to continue on. Now, I really don't need to spend too much time here. This is something that you're all very aware of, but just to start us off, hypercholesterolemia, also sometimes called hyperlipidemia, dyslipidemia, or just high cholesterol, can, when untreated, lead to plaque deposition in the arteries, and as you would be well aware, buildup of plaque in blood vessels can lead to things like heart attack, stroke, coronary, carotid and peripheral artery disease, microvascular disease, and in severe cases, sudden cardiac arrest or sudden cardiac death. So hypercholesterolemia, there's sort of many reasons why someone could develop hypercholesterolemia, and Tania's talk has actually set us up really well here, having sort of covered some of the lifestyle factors and sort of complex interactions with other health conditions. It's also good to be aware that certain drugs can cause someone's cholesterol levels to rise, but you know, the one that I'm going to be focusing on today is this genetic component here. So genetic hypercholesterolemia or familial hypercholesterolemia is an autosomal dominantly inherited disorder. So you can kind of see from this little picture over here on the left that if someone has FH, then each of their children would have a 50-50 or 1 in 2 chance of inheriting FH. FH causes a marked elevation in low density lipoprotein cholesterol, mostly from birth, which leads to an increased risk of premature atherosclerotic cardiovascular disease. Physical signs of FH don't happen in everybody, but the ones that can happen and we see most often are tendinous xanthomata, so that can be seen in these pictures here. So in A, that's one on the back of the calves there, and B on the back of the hands. You can get xanthelasmas, which are in this picture here, commonly around the eyes, and then the arcus that can be seen here in picture D. Now, FH does affect approximately 1 in 250 Australians. So, as Peter rightfully said, you more than likely have someone in your practice or that you are managing that has FH. But it is significantly underdiagnosed in the community. And I should mention that some populations have an even higher sort of burden of FH. So, for example, our Lebanese community, we're sitting more at the sort of 1 in 75-ish people that have FH. So the first way of diagnosing FH, even though it's a genetic condition, it can be diagnosed sort of clinically by using the Dutch Lipid Clinic Network score or other similar tools. And this kind of takes into consideration an individual's personal and family history to give you an overall likelihood of someone having familial hypercholesterolemia. Importantly, this tool is actually also what's used in the criteria to access Medicare rebated genetic testing for FH. So for someone to access genetic testing, they sort of almost already have to go through this sort of clinical diagnosis using the Dutch Lipid Clinic Network score. And these criteria here, which are the Medicare criteria for diagnostic genetic testing, are the same as what we really use in our clinic to offer someone FH genetic testing. So after the clinical diagnosis, we can then obviously go on to see if someone has a genetic diagnosis of FH, and that involves sort of doing a small panel test, but essentially to have genetic FH, you need a pathogenic or likely pathogenic variant in either the LDLR, ApoB, or PCSK9 genes. So on the right-hand side of the screen, that's just an example of one of the reports that comes out from our lab here at RPA, and this is one of our patients. And as you can see here, they have a variant in the ApoB gene, which is classified as a pathogenic variant. But this sort of panel testing can only be ordered by specialists or consultant physicians. So I guess that's kind of our role in the genetic testing. Can also be obviously ordered by cardiologists as well. One thing to note here is that sometimes pathogenic or likely pathogenic isn't the only classification of a genetic variant that you can have. We can also get what we call a variant of uncertain significance, which importantly cannot be used in cascade screening, which is what we're going to talk about next. So cascade screening is sort of talking about screening of families of people with FH, sometimes also known as predictive testing in the genetic sense. But for the purposes of FH, we generally go with the terminology of cascade screening. And I thought I'd just go the old classic of the who, what, when, where, and why of the cascade screening. So cascade screening, we recommend should be done for all first and second degree relatives of an individual that's diagnosed with FH. So first degree relatives, that includes your parents, children, siblings, and then second degree relatives obviously extends out to the next level of family, so grandparents, grandchildren, aunts and uncles, those sorts of people. Now, cascade screening for FH can actually take a couple of different methods or routes, I guess. So you can do cascade screening just through lipid studies. These are particularly useful, and we still recommend them for people even when we do the genetic testing, but we don't find a genetic test result. So lipid studies is what we sort of recommend for those families. But then, of course, you can do the genetic testing. And so that's for families where there's a known genetic variant, and we just test the individual for that one genetic variant that's been found in the family. We don't need to sort of go looking through all of the possible genes again. When to do the cascade screening. So sort of from about 10 years old is a good time to do it. Now, the reason for this, and Dr. Sullivan, I believe, is going to go into this a little bit further when he speaks, is that this is when we can commence treatment for people with FH. So it sort of makes sense to do that cascade screening around that time. Some families like to do it earlier, but sort of 8 to 10 years is sort of I find a really great time, because generally the kids kind of can understand what you're talking to them about, at least in a sort of basic sense. So, you know, whilst you could do the genetic testing from any age, sort of close to that 10 years old is sort of our preference. I'm going to leave the where for now. We'll come back to that. But you know, why should we do this cascade screening? And I guess that's to identify all of the at-risk individuals. As we mentioned before, we should be seeing about 1 in 250 patients having FH, but you know, the incidence of that we actually see is much lower. Having a diagnosis can allow early access to treatment and management. And of course, that then ultimately reduces an individual's lifetime risk of ASCVD. And just as sort of a little example, so if we say that this woman here was the individual diagnosed with FH, the amount of people in her family that we sort of recommend screening and that can benefit from her diagnosis. So these are all her first degree relatives shown in this picture here, with the blue highlighting, and then this is all of her second degree relatives. So you can see that it quite quickly expands out to the number of at-risk relatives. And this is one of our actual clinic families. I haven't just randomly drawn you guys a pedigree. So I guess if we move on to the kind of where should this cascade screening be done, and I guess very excitingly for us, general practitioners are now able to order this cascade genetic testing for FH due to a recent change in the Medicare benefit schedule. So this is the item number here where GPs can now order this genetic testing. And we kind of feel that generally GPs are sort of the best placed to be able to do this, given that you often have a really well established and trusting relationship with the patients. It reduces their barrier to being able to access this kind of testing that's traditionally been carried out in genetic services. And general practitioners also already do a really great job at managing hypercholesterolemia more generally. So, rather than sending the patient out to a tertiary service just for the purpose of genetic testing and then coming back to their practitioner for management, it can kind of all be done in the same setting now. However, we kind of understand that this is quite new in the space of primary care. It's the first predictive or cascade genetic test that can be ordered by general practitioners. Like I said, that's actually normally done in a genetic service, so either by genetic counsellors like myself or by a geneticist. And we're also really aware of the time restrictions faced by all healthcare workers. And so we wanted to develop a model of care that kind of shared this burden a little bit and helped with the integration of this type of testing into general practice, as this probably isn't going to be the only thing or the only condition that ends up having a Medicare item number or the availability of general practitioners to order this type of testing. So this model was developed alongside general practitioners here at our clinic and is being refined as we receive feedback on the model. So essentially how it runs is that we see the proband or initial patient in our clinic. They end up with a genetic diagnosis of familial hypercholesterolemia, and we give them a letter to give to their relatives. On this letter, it has a little bit of brief information about familial hypercholesterolemia, as well as a QR code that the relative can scan to input their details into and basically express their interest in having genetic testing done. When we receive one of these forms that's been completed, we then send out a cascade screening information package to both the relative and to their nominated general practitioner. And this package includes some more information on FH, how to conduct the cascade screening. We also include an example of a pathology form and what needs to be included on a pathology form when ordering genetic testing, and a consent form, as informed consent is a really key part of genetic testing. So then the patient obviously attends an appointment with their GP to discuss this testing and resolve any questions that they might have outstanding. The patient consents, then the genetic test is ordered. When the result becomes available, And if it's ordered through our laboratory, I will know when it becomes available. We then send out a second package to the GP to help with providing the results of the testing and the kind of management that needs to come after someone's being diagnosed with FH. And it goes in a nice sort of little circle. If we diagnose a new family member with FH, in the results package, we include a copy of the family letter that can then be given to sort of the next lot of relatives, I guess. But most importantly, I guess down here is that throughout this model of care, we provide all of our details to both the patients and practitioners so they can call me. Actually, I'm the person that will answer the phone with any sort of questions or concerns that they might have about the testing. So I guess one of the sort of main things about sort of ordering predictive testing is that the counselling and consent process that goes along with it. So here on the screen, I've got an example of the New South Wales Health consent form, which is available to be used by any clinician. I know that when I worked in Tasmania, we use this consent form as it's just a really great example of a consent form. There's kind of two main things to point out here. This is the back of the consent form here, and this section kind of goes through in a stepwise fashion what should be discussed with a patient when ordering predictive genetic testing or any genetic testing. So you can kind of use this as a bit of a guide to what you should be discussing. Now, given it is a general consent form, there will be a few things on here that are not relevant for predictive testing, such as identifying an unknown or uncertain significance variant, and identifying unexpected family relationships is not really possible with that type of testing. But it does give a sort of general guide about what to discuss, including genetic testing not being a general health test. So whether or not they come back with a positive or negative result for FH, it kind of doesn't give us a indication of how their disease will progress over time. It also prompts you to sort of discuss what's sort of big in the field of genetics at the moment, which is the potential impacts of insurance on genetic testing, which I know worries a lot of people. And this is kind of the main reason that I get cited in clinic for people not wanting to pursue genetic testing. In FH, I think we can be reasonably reassuring about this if somebody has questions, given that people with FH are nearly always symptomatic. So we'll nearly always have some sort of high cholesterol, and this is already something that's asked of people when they apply for life insurance. And to note that it's only if individuals are after a certain amount of cover that they get asked about whether or not they've had any genetic testing. And additionally, it doesn't affect sort of health insurance or insurance related to an individual's super. Now, the second, I guess, very important part of this consent form is this grey section here, which essentially just has a couple of yes or no questions on it, with the most important being this question here. So the consent form involves a section that where people can give permission for their genetic test result to be shared with healthcare practitioners of their family members. So this is particularly important because if people are getting tested at different laboratories, for example, so RPA is not the only laboratory that offers this genetic testing, then the laboratory generally need a copy of their genetic test result to be able to carry out this cascade or predictive testing. And this consent form, I guess, gives us permission to do that. So I guess moving on from there is, how do you request the testing practically. So this is just an excerpt of the forms that I generally use in clinic. What should be included are basic information on the variant. So mostly I just put the gene that it's been found in, so that the specimen reception know how to process this and what tests being ordered. You need to include how your patient is related to the family member with a known genetic variant. Otherwise, sort of the result can't be interpreted by the laboratory. And as I mentioned in the previous slide, you need to include either a copy of the report of the original person that had genetic testing, or the report or laboratory number if it's being sent to the same laboratory for testing. Without all of that information, unfortunately, the testing can't happen. And a lot of you, if you've tried to order this testing, may have got a call from our wonderful genetic pathology registrar who, unfortunately, is his job to tell people when genetic testing or the correct information hasn't been included on the form. Our lab also likes it if you can provide the most recent lipid results for a patient. But obviously, this isn't always possible. If, they've only just found out that FH is in their family, they may have never had their cholesterol checked, especially if they're a young person. So you can always just run lipid studies in conjunction with the genetic testing, which is what we include on our lab form here. Now, some of you may have noticed that I actually say either blood samples or saliva samples. And so genetic testing can be done on a saliva sample, and we have saliva kits that we're happy to provide to practitioners if their patients would prefer to do it on a saliva sample. And we find that this is particularly useful for our younger cohort, so our small children that we do the testing in. Often, they're a little bit needle phobic, that kind of thing. And this can remove the barrier, I guess, to them being checked of whether or not they have familial hypercholesterolemia, if they're a little bit scared of the lipid studies, which involve a traditional blood test. So once you've done all of that, you've ordered the genetic testing, I guess the question is, where do we go next? So if you get a negative result from genetic testing and your patient has normal LDL cholesterol levels, then they would not have a diagnosis of FH, and they can go straight back to routine population screening of cholesterol. If you get a negative genetic test result and an individual still has elevated LDL cholesterol, we would sort of classify this as non-familial or non-genetic hypercholesterolemia. And as we mentioned off top, cholesterol can be raised for a number of reasons, and we would kind of direct people to the hyperlipidemia guidelines on the health pathways. If you get a positive genetic test result and your individual has elevated LDL cholesterol, then pretty obviously we have a diagnosis of FH in that individual. And there are several sort of guidelines available for treating patients with FH. In particular, the Atherosclerosis Society of Australasia have some great resources about both lifestyle and medications for use in people with FH. Now, very uncommonly, you can get an individual that has a positive genetic test result, but a normal LDL cholesterol. Now, we would still say that these people have familial hypercholesterolemia. They may have some other protective factors, but this is kind of where we would recommend that you perhaps reach out to someone like Dr. Sullivan, who can kind of evaluate what sort of management to put in place for this individual. So I've just thought I'd take you through a very brief case example of how this might work in a family. So we've got this individual here, Norma. She's our proband. She's a 52-year-old female. Her lipid studies have come back at quite a significantly elevated level. So her LDL cholesterol was sitting at 8 millimoles per litre. She was diagnosed with ischemic heart disease at 48 years old. She has a significant family history, so we can see her daughter here, Lucy, has also been diagnosed with high cholesterol. She had a brother that passed away at 32 years old from myocardial infarction, and a second brother that's had a cabbage. And then up a sort of next generation, her dad's also passed away from a myocardial infarction, with 2 of his siblings having passed away quite suddenly as well. And she doesn't have any other risk factors for ASCVD. So she's a non-smoker, she doesn't really drink, she's in normal weight range, all of these kinds of things. So that's sort of a pretty suspicious profile for someone with FH. Now, if Norma presented to your clinic, you could run the Dutch Lipid Clinic Network score, and we can kind of see in this example that Norma comes out with a score of 10, which puts her in that definite sort of FH category. So clinically, she has FH, and this would be a really great example of someone who to refer to our clinic so that we can organise the initial genetic testing in the family. And that's what's happened in Norma. So genetic testing was ordered, and it was found that Norma had a pathogenic variant in the LDLR gene, which is the most common gene that we find genetic changes in. This then allowed genetic testing to happen in her 2 children, so Lucy and Luke. Lucy was found, maybe unsurprisingly, to have a variant, have inherited this variant from her mother, and Luke was found that he didn't inherit this variant. So Luke at 24 years old, instead of bringing him in for screening every couple of years of his cholesterol levels, he can be released back to population sort of cholesterol management. And probably most importantly for the family at the time is that his young daughter, Daisy, is not at risk of developing FH. So it can't skip a generation. Daisy doesn't need to be monitored for FH at all. But then if we sort of maybe fast forward and we sort of talk about Lucy for a minute, who, if we remember, was tested positive for the familial variant. In 2024, she has 2 young children, Isaac, who's 11 years old, and Sarah, who is 7. And they are living in rural New South Wales. And Isaac is severely needle phobic. So who sort of, I guess this is a really great example where a GP is really well placed to order the genetic testing. The children already know their GP. They don't have to come in to a tertiary hospital service to have this genetic testing done. When they, this would be a few hour round trip for this family. So additionally, the GP then ordered the FH cascade screening via a saliva sample. So there wasn't that barrier for particularly Isaac to having testing and potentially missing out on treatment because of his needle phobia. And actually really nicely for this family, both children came back as negative for the familial variant. So they, again, both can go back to general population screening. So really quickly, I guess to sum it all up, what can be done in primary care before referring on to our lipid clinic here? So you can assess an individual for their overall sort of cardiovascular disease risk, which gives a really good indication of when treatment should be initiated and those sorts of things. It's really great if a trial of treatment can be initiated before being referred, because unfortunately we have a really long wait list. And if a patient hasn't been trialed on a treatment of statin, for example, it's probably going to just prolong them accessing what is the first line treatment for hypercholesterolemia. Tania's really spoken about optimizing lifestyle factors, assessing for secondary causes, and using that Dutch Lipid Clinic Network score to assess whether or not your patient might even qualify for genetic testing. So when to refer to us? When a patient needs genetic testing, so nobody else in the family has been tested yet, we'll do that initial genetic testing. When a patient's unable to meet their lipid targets for, a variety of reasons, patients under 18 years old, we're happy to see patients with established cardiovascular disease or with multiple cardiovascular disease risk factors and complex comorbidities. And I thought I'd just also briefly mention homozygous FH. So unfortunately, we get some people that have 2 genetic variants, which causes a much more severe version of hypercholesterolemia, and they're kind of best placed to be managed by a tertiary service. There are a few resources that can be used. So I mentioned the Australian Atherosclerosis Society. This is their FH page. They also have an online version of the Dutch Lipid Clinic Network score calculator. There's a really great fact sheet that was developed by the Centre of Genetics Education, which can be given to individuals. And then this is sort of currently being updated. So hopefully very soon, though, you'll be able to go straight to the health pathways, and they have a specific page, or they will have a specific page on FH cascade screening. And if you want a more in-depth resource, there's this great paper that Professor Sullivan contributed to on specific sort of management guidelines for people with FH. These are just our contact details. So if you want to refer some to our clinic, unfortunately, we don't have an referral service. But this is our general clinic information. And then this is my direct information if you have specific testing inquiries. And then very briefly, if any of you have happened to take part in this cascade screening model already, you may like to scan this lovely QR code and give your feedback on it so that we can help develop it further. So I'll just hand over to Professor Sullivan now, who's just going to briefly retouch on some of the ideas regarding cascade screening, as well as a brief treatment update. So David, if...
Thank you, Maddie. And Maddie's done a really wonderful job in the main process that we hope to achieve tonight, which is to try and demystify this area to a large extent. I'll just quickly comment that some questions have been coming in. I've been trying to answer them, but I think the latter ones are probably relating a little bit more towards Maddie's input. And so I might invite her to try and dash off a couple of answers. And where possible, I'll allude to any remaining questions as we go through the presentation. In terms of a tag team, I'm actually going to rely on Maddie to forward the slides, and she's already answered the question about what is family cascade screening. And I'd like to just say at the outset that it is also a very needful area. Being genetics, it's got a mystique about it. And I think because of maybe even some commercial reasons, the aspect of trying to find index cases with index case testing has been quite successful and has permeated primary care to quite a good degree. But the whole cost effectiveness of family cascade screening hinges on following up the families and the relatives. And that's been sort of left in the hands of specialists. We need the specialists in families, and they are family practitioners. So we really need primary care, family practitioners to pick up this great opportunity and make it their own. So Maddie, next slide, please. And this is showing, oops, sorry, actually, if you can just go back one to those, sorry, back another. Yeah, so this is showing a case not dissimilar to the one Maddie used previously, and it shows the classical family cascade screening of the search amongst siblings and children for other affected family members. And the next animation just illustrates the fact that familial hypercholesterolemia will remain a burning candidate for neonatal testing and universal screening at birth. It may eventually become one of the panel of neonatal screening abnormalities, But family cascade screening would then still be relevant, because you would then have children identified as being affected, and we would need to do what is actually the reverse process, which is called reverse cascade screening. And that is also a very appealing public health model, because what you would have is a young family with the parents undiagnosed and really very close to their at-risk ages for developing the consequences of familial hypercholesterolemia. So cascade screening can go in two directions. Both of them are very relevant to family practitioners, and we call them either cascade screening or reverse cascade screening, and they might fit into different public health models. Next slide, please. And I just want to make the second point that it is the detection of the other affected relatives that drives the cost effectiveness of this whole strategy. Medicare genetic testing has been brought in because it is cost effective. And if we leave it leaning towards index case detection without the family cascade screening follow-up, it's going to be analysed by federal government as non-cost effective, and it may even be that the rebates are terminated, or some other adverse outcomes might occur. And just the degree of the efficiency can be seen in that bottom line. For every index case you detect, once you institute family cascade screening, you find on average another 2.5 relatives. The potential goes way beyond that. When done in the gold case standard of the Netherlands, they used to have a dedicated process which would involve some lovely initiatives. They'd have sample collectors who'd go to affected families' houses. They'd arrange family reunions and have someone sitting in the corner collecting samples if people were willing. And through those sorts of initiatives, they were able to usually diagnose another 8 cases within 2 years, and they were also able to reassure another 8 members of the family that they didn't have a problem. So the impact can be really quite substantial. Next slide, please. Next slide. Thank you. And one of the implications of family cascade screening is that we are going to tend to find people earlier on in life. And this is another area where we probably have to reverse some established thinking. You'd all be familiar with absolute risk calculators, and those absolute risk calculators really have age as the main driver and as the main risk factor, and that tilts our current therapeutic guidelines towards treatment of older patients and a neglect of treatment in younger patients. We're trying to reverse that thinking, because as this slide shows, you can see some different individuals here progressing towards that green horizontal line, which is the threshold for the onset of high risk of cardiovascular disease. Without FH, you can see bottom green line as intersecting that at somewhere along the lines towards normal life expectancy, maybe 55 years, depending on the presence or absence of other risk factors. And you could see that a heterozygous FH patient might intersect that line at 35 years because of their higher LDL cholesterol. You can see that if you identify that patient out in their 20s and start high-dose statins sufficient to get a very major reversal in their LDL cholesterol, that you can delay the onset of the cardiovascular disease, but you're actually far more successful if you start soon after age 10, first or second decade of life. You don't need to be as aggressive, and you end up with a better outcome. So the whole trend within cardiovascular prevention is one towards earlier intervention with less invasive intensity of therapy, with a very realistic expectation of better outcomes as a consequence of all of that. Next slide, please. So here is the Medicare descriptor for the primary care physician's ability to initiate cascade screening. And you can see that the cost of that screening is actually quite a lot less expensive than the index case screening. An index case screening requires the laboratory to go through the whole of the genetic sequence of those relevant genes, looking for the variants we've been explaining, not knowing where to look. The part of the efficiency of this system is that once you know the variant in a family, you don't have to do that exhaustive process. You just go back and use simpler techniques to see whether the family variant is present or absent in that individual. That's why there's a lower rebate. And there's a little bit of an adverse commercial effect there. We find that there's probably more emphasis from the laboratory side for the process of index case detection, and we now need to match that with a greater awareness of the benefits that flow from the subsequent family cascade component. Next slide, please. And so even the MBS provides an appropriate stepwise model for decision making towards the ordering of the test, and the qualifying criteria for cascade screening really are very simple. The analysis of those genes in a first or second degree relative of a patient with documented variants of this nature, and can be requested by a general practitioner or other medical practitioners. And so I think one of the remaining stumbling blocks probably is that, unfortunately, the Medicare system, whilst it facilitates the test ordering, it doesn't really do enough to facilitate the more detailed recording of family history, the greater awareness of family history that needs to be developed amongst both the patient and the primary care physician. It's an area where I think we need to do more work and get some item numbers which pay more attention to family history recording. Next slide, please. I'm just going to try to convince you that genetics inevitably is going to become a part of your life. And that's the reason for trying to demystify it. First of all, it's probably our genetic awareness which is going to drive most of our therapeutic advances. And I'm going to give you the example of the recently introduced PCSK9 inhibitors. They were discovered from a special instance of familial hypercholesterolemia. It turns out that PCSK9 is adverse because it's like a fine-tuning mechanism which removes LDL receptors once they've been operating for a while, and once they've replenished the cell's cholesterol level. So a bit of reverse psychology or reverse logic. If too much PCSK9 is bad for you, maybe not enough is good for you. Next slide, please. And so I'm going to tell you the story of how the treatment category developed. And I'm going to concentrate on the endpoint, which is the recent arrival of what we call antisense anti-PCSK9 therapy, which is typified by the agent inclisiran. So I'll just stop the extra moving forward of things. I'm taking it in steps. The first step in the process was the understanding of familial hypercholesterolemia as a disruption of the so-called lock and key interaction between the receptor and its ligand to internalize cholesterol. The second component on the left there with the green background was the realization that not all cases of familial hypercholesterolemia could be explained by defects in the lock or the key, and hence it was the fine-tuning mechanism of PCSK9. that's what was detected in the brown background slide that replicates what I showed you before, that the increase in lack of LDL receptors was found to be due to too much PCSK9, and hence PCSK9 was recognized. The bar graph on the lower left-hand panel is showing you a technique called Mendelian randomization, which I've highlighted. Mendelian randomization is the use of genetic information in an epidemiological setting. And it means that you can actually get the same sort of information that you usually get in a randomized controlled trial, but you can get it from just a single epidemiological study. And the rules of Mendelian randomization are that if the gene pattern and the blood biomarker pattern that it controls both have the same effect on the disease that you're interested in this case cardiovascular disease, it suggests that the biomarker is the cause of the disease pattern, or is a cause of the disease pattern, and that the gene that is controlling that biomarker is a good target for possible therapy. And so when you apply that, you get a massive acceleration of the development of new and effective treatments, because if you knew the genotype, you can immediately work out the sequence. In the bottom graph there, that's the target identification. You know the sequence. You can then test out the mirror image of that sequence in lab tests, both in cells and in other assays, and see which ones are best at interfering with that gene product. You can very quickly move on to animal models, because you know, oh, sorry, go back that slide. You can move on to animal models with the confidence that what you're looking at is likely to prevent the disease, because your Mendelian randomization told you what the effect of the genes over time was going to be in humans, and it also told you what potential side effects might come with that particular effect. So you can do your whole development program with an expectation of successful therapy with a low likelihood of side effects. So that's what's illustrated in those lower panels. That's what's been the case with the development of antisense PCSK9 therapy, which is inclisiran. It's taken about 15 years as opposed to 30 years, which is the usual product development. It's been much cheaper. It will result in cheaper therapies, et cetera, et cetera. So genetic information interpreted in the light of Mendelian randomization is going to drive the products that come to you for treatment, and they're going to be particularly effective in genetic conditions like familial hypercholesterolemia. Next slide, please.
David, I can give you one more minute so we can get to some questions, please.
Yes, good. Thanks, Peter. I think this is close to my last slide, and it's just to show that the reason for this technique is that we used to do randomized controlled trials on the bottom, where you had a small effect for a small number of years, but the genetic changes associated with the top line give you a much steeper slope, because those genetic changes operate through the whole of life. And although the changes are small, they are successful in predicting what the effect of those changes are when sustained over a much longer period of time. Next slide, please.
That's it. You didn't have any more slides.
Sorry, I thought I had a summary slide. So it really is
sorry.
maybe just to revert back to the importance of the family cascade component of these genetic strategies, and therefore the need to really team up with experts in family management, and that's your primary care physician. And we're here to support those efforts. Please let us know how we can best do that.
Okay, well, thanks very much, David. We have a number of questions. We're not going to be able to get to all of them, so I'll just pick a few. I think you've answered the first part of this question, Madeline, about what age should statins be started. I think you said about 8 to 10. But what about in pregnancy or women of childbearing age?
That's an important question, and we would routinely avoid statin. We would avoid any pharmacological treatment with the same sort of provisos that Tania gave. It's not necessarily a disaster. There have been cases where people have fallen pregnant, but there has been, with statins being so widely used, there have been enough birth defects to say that we really can't approve it. However, there are theories that our whole metabolic profile might be set in utero, and I think people may go back and look at whether, in fact, in severe cases, cholesterol-lowering treatments should be contemplated. It's an important issue with our new therapies because one injection of inclisiran will last you 6 months.
Mm-hmm. Okay, David, you mentioned Tania, and Tania, thank you very much for getting back to us on the question of dropouts of patients on semaglutide in the obesity trial. You told us, you're telling us that side effects in the active group caused 7% dropout versus 3.1% in the placebo. So not as high as some people might have thought. David, another question which could be the topic for a whole other talk is what do you do in patients who just simply cannot tolerate statins?
I think the main point to make is that we don't have any tricks that you don't have. We can't go and bend the PBS guidelines and get them PCSK9 inhibitors or anything else like that. And we're just doing some work in the field at the moment with a psychologist who is pointing out how important the framing of the initial introduction of therapy is, that if you frame it positively, then the chance of the so-called nocebo effect is much less. But again, I really liked Tania's tricks, and I suppose our tricks are to rely very heavily on ezetimibe, pointing out that it is a non-statin, that if anything, it should have the opposite effect on some of these problematic areas. We also stressed, I think, the implausibility of concerns about detrimental effects on mood or cognitive function, and we probably don't go into the unreliability of reproducing statin side effects. I just don't think we win any battles that way. If people have made up their mind that they're not going to take them, we've just got to accept as that. But with an ezetimibe background, I think you can ease up with very low dose statin therapy. You can maybe get up to around about a 20% LDL reduction, and after that, everything is compromised. The other main strategy, I think, is probably putting the patient in charge of their treatment decisions. I think it doesn't matter if they stop and start a bit. It doesn't matter if they take little breaks. If they're making common sense decisions, I think we can empower them to continue doing so.
Any valid role for CoQ10?
That was patented by the Nobel Prize winners whose work led to the discovery of statins. You can make up a story that because CoQ10 is produced down the cholesterol synthetic pathway, it will be reduced. However, it may not be reduced at the individual lipoprotein level. The reason it's low in the plasma is because you've reduced the number of LDL which carry CoQ10. The patent was never actually enforced because I think there has not been any demonstration of a reliable benefit of CoQ10. One thing to be counteracted, I think, is often some pharmacists were saying you needed to take CoQ10 to avoid a deterioration in cardiac output. With statins, there's no such deterioration. There's no such protection by CoQ10.
Madeline, you might like to take this one. If you know a child has normal cholesterol, but the mother has FH, do you still need to do the genetic testing?
We still say that it has a benefit. Obviously, there child's probably very unlikely to have FH, but as I mentioned, in some circumstances, the child could or individual could still have FH and just have a normal cholesterol level, which happens in sort of a low percentage of people. And so if you wanted to be, I guess the benefit with genetic testing is that it gives you a 100% answer, so a yes or no, rather than a most likely answer. And if they truly don't have FH shown on a genetic test, then we know that their future children, so the next generation, aren't at risk of FH and don't need to be tested for it.
Madeline,
Can I
sorry,
just add
David.
at the end? Can I just add at the end? I thoroughly
Please.
support Madeline's answer, and it's a demonstration of the fact that genetic counselling is actually more difficult in the situation where you expect a negative outcome than it is where you expect a positive outcome. It's actually more important and more difficult. And that's why we rely on Madeline's skills.
Thanks, David. Briefly, please, Madeline, because you did mention the effect of testing on insurance in the index case. What about the effect on family members who might be shown up as a result of the cascade testing?
Yeah, so if it's only their relative that's had a positive genetic test result, they are under sort of no obligation to share that with their insurance company. So say, mum's got a positive genetic test result, and you have yet to undergo genetic testing, you don't need to tell them about mum's positive genetic test result. And we often encourage people, if they're looking into insurance, to get it sorted before doing genetic testing. Additionally, I think the threshold at the moment is about $500,000. So if you're asking for life insurance under that, then you can't be asked about a genetic test result either. But I guess you've got to keep in mind that they will still ask about your family history anyways. And often people with a family history of FH have a strong family history of cardiovascular disease, which the insurance companies can use regardless. Now, hopefully we'll have an update for you soon saying that insurance companies can't ask you about genetic test results anymore. But that is currently sitting with Parliament. So keep your eyes on the news for that, I guess.
Thanks, Madeline. Tania, I might give the last question to you, and thank you very much for sticking around with us to field some more questions. But there's a question here about patients on VLCD seeming to get rises in ALT. Have you seen this? Are liver problems common in patients on very low-calorie diets?
Look, it's been reported, and it's something that we used to be worried about, and we did regular liver function testing in our patients, and it just never seemed to happen. But funnily enough, I've got a patient in one of the drug trials who's lost a huge amount of weight, and her liver function tests have got a bit worse. So there is something about steatosis, steatohepatitis getting worse with weight loss. We don't monitor for it. In my 20 plus more, 30 years of practice in this field, I've never had a patient who's run into problems with it. But obviously in the pharma trials, they monitor everything. And there is a patient currently and she had a liver ultrasound and she's got some steatosis. And I suspect that when her weight stabilizes and she's not losing, her liver function will improve. So it is described, and I even found something of somebody getting quite bad liver dysfunction with marked weight loss. I don't know if it was intentional. I can't remember if it was intentional or not. But I don't think it's something that we need to worry about very much at all.
Great, thank you. Look, we are over time, so I am going to have to call a halt. I apologise to the questioners whose questions I haven't been able to fit in because of the time constraint. But despite that, I think you'll agree we've had some great presentations from three excellent speakers. I'd like to thank Professor Tania Markovic, Professor David Sullivan and Madeline Calder for sharing their expertise with us tonight. And I'd like to thank you all on the webinar for attending. So thanks very much, and good evening to you all.